Welcome back to the deep dive. Today, we're really getting into the specifics of a medical case report.
Yeah, one that looks at a very particular orthopedic challenge.
Exactly. How do you fix a foot bone that's too short without, causing other problems down the line?
Mm-hmm.
We're looking at a condition called brachymetatarsia and a really interesting tweak to a surgical technique.
And it's fascinating, isn't it? How sometimes a small change, a subtle modification, can make such a huge difference for patients.
Totally. Our main source today is a case report from the Journal of Orthopaedic Case Reports. It gives us a really detailed view of this approach.
Right. So maybe we should start with the basics. What exactly is brachymetatarsia?
Good idea. So it sounds complicated, but brachymetatarsia is essentially a birth defect, a congenital thing where one or more of the metatarsal bones in the foot are just shorter than they should be.
Right. Those are the long bones connecting your midfoot to your toes.
Yeah. So imagine looking down at your foot and one toe just doesn't line up. It looks shorter, set back.
And that's not just about looks, is it?
Not at all. It causes real discomfort, functional issues too. It's pretty rare, affects maybe 0.02% to 0.05% of people.
Wow, that is rare.
And here's something really striking. It predominantly affects women. The ratio is something like 25-1, female to male.
25-1, that's significant.
It is. And it usually involves the fourth metatarsal, the one leading to your fourth toe. Often happens in both feet, too.
So bilateral cases are common.
Over 50%, yeah. And because it affects women so much more, there are often, higher expectations around cosmetic appearance and function when they look for treatment.
That makes sense. And thinking about why it happens, the biology behind it, it's usually thought to be an issue with the growth plate. At the end of the bone, the epiphysis.
Right, the growth plate.
Yeah, it either grows too slowly or it fuses shut too early, so the bone just stops lengthening prematurely. And while often it's just, congenital, sometimes it can be linked with other conditions.
Right.
Things like sickle cell anemia, Turner syndrome, even Down syndrome are mentioned in the report.
It's interesting.
But for the patient, the experience is often about pain in the front of the foot, maybe calluses forming because the weight isn't distributed properly.
Mm-hmm.
And as you said, real trouble finding shoes that fit comfortably because of that toe alignment issue. It really impacts daily life.
It absolutely does. Which brings us nicely to the specific case in this report. We're talking about a 21-year-old woman.
Okay.
She came in with this condition, brachymetatarsia, affecting the fourth metatarsal on both feet. Bilateral, just like we mentioned.
And she'd had it since childhood.
Yeah. Pain and the cosmetic deformity since she was a kid. And you can imagine, by 21, she'd tried the usual things, orthotics, special shoe inserts, physiotherapy.
The conservative stuff first.
Right. But nothing really gave her lasting relief. She described her feet as aesthetically unpleasing, which is, pretty direct language about how it affected her self-image.
Understandable. She just wanted a solution.
Exactly. Something definitive.
So what did the doctors find when they examined her?
Well, the clinical picture was pretty clear. Both fourth toes were obviously short. She had tenderness right over that fourth metatarsal area. And she had what they call a cock-up deformity.
Ah, yeah, where the toe kind of points upwards.
Exactly. It rides high. And also a sulcus sign on the sole, like little groove or dip where the toe pulls back.
Affecting the pressure points.
Right. And the x-rays confirmed everything. A significant shortening 2 centimeters on both fourth metatarsals.
2 centimeters is quite a lot in that part of the foot.
It really is. And even the bone in the toe itself, the proximal phalanx, was about 5 millimeters short on both sides.
Wow.
But critically, the x-rays showed that the Liliev parabolic arch was completely off.
Okay, let's pause there. The Liliev arch, why is that so important?
It's basically the natural curve formed by the ends of your metatarsal bones. Think of the ball of your foot. That curve is vital for how your foot bears weight and pushes off when you walk.
Right, for normal foot mechanics.
Exactly. So if that arch is disrupted, like in her case, it explains all the functional problems, the pain, the discomfort.
Got it. So her case clearly needed more than just insoles. Surgery was the next step.
It was. Now, typically, there are a couple of main surgical routes. One is called acute lengthening.
Where they cut the bone and immediately put in a graft.
Yeah, bridge the gap right away. But that comes with higher risks the graft might not take, or you could have issues with blood supply, even nerve damage.
Okay, so high-risk profile. What's the other main option?
The more common one is sequential lengthening, using something called distraction osteogenesis.
Ah. The bone stretching technique.
Precisely. And this is where our case report gets really interesting. Because while distraction is often preferred, it has its own major potential downside?
Right. Let's unpack distraction osteogenesis a bit. It's actually quite amazing. Surgeons make a cut in the bone, the osteotomy, and then they attach an external fixator device. Over time, usually starting a week or so after surgery, the patient turns a small dial on the fixator.
Very slowly pulling the two bone ends apart.
Exactly. Maybe a millimeter a day, split into smaller increments, and the body responds by filling that gradually widening gap with new bone.
It's like tricking the body into growing the bone longer.
It is.
Yeah.
And it allows the soft tissues, muscles, nerves, blood vessels to stretch and adapt gradually too, which is a big advantage over the acute method. Less risk of tissue damage.
Okay, that sounds pretty good. So what's the catch? What's the downside you mentioned?
The big one, the most common serious complication with this technique for brachymetatarsia is subluxation of the MTP joint.
MTP joint. That's the joint at the base of the toe, right? Connecting to the metatarsal?
Exactly, metatarsophalangeal joint.
Yeah.
Subluxation means it partially dislocates. As you lengthen the metatarsal, the forces can pull that toe joint out of alignment.
Oh, okay. That sounds painful and counterproductive.
It really is. It can lead to severe pain, joint stiffness, and basically ruin the functional outcome, even if the bone lengthening itself is successful.
So you fix one problem but create another?
Potentially, yes. And other things can happen too, like infections where the pins of the fixator go into the skin and bone, or the new bone might be slow to harden.
Right. So this brings us to the modification in this case report. They were doing distraction osteogenesis, but they added something.
Yes, this is the key innovation. How do you get the lengthening without the MTP joint subluxation?
That's the million-dollar question, right?
It is. So they use the standard gradual lengthening with an external rail fixator, but, and this is crucial, they combine it with axial trans-articular K-wire stabilization of that MTP joint.
Okay, break that down. Axial trans-articular K-wire.
So a K-wire is just a thin, smooth surgical pin. Trans-articular means it goes across the joint. Axial means it's placed along the line of the toe and bone.
So they put a pin right through the toe, across the MTP joint, and into the metatarsal bone itself.
Precisely. It essentially locks or immobilizes that MTP joint temporarily.
Ah, like putting the joint in a cast internally, almost.
That's a great way to think about it.
Yeah.
It holds the joint stable and perfectly aligned throughout the entire distraction period while that metatarsal is being lengthened. It directly prevents the joint from subluxating or slipping.
That makes so much sense. It directly tackles that main complication head on.
Exactly. It ensures the new bone forms in the right alignment relative to a stable joint.
So surgically, what did that involve? You mentioned the fixator pins.
Right. So a small incision, about 4 centimeters along the top of the fourth metatarsal. Then they put in 4 Schanz pins. Those are the threaded pins that anchor the external fixator. 2 near the ankle side, 2 near the toe side of where the bone cut would be.
Okay.
Then they perform the osteotomy, the surgical cut in the bone. Then, before attaching the main body of the external fixator, they insert that K-wire down the toe across the MTP joint.
Got it. K-wire first for stability.
Yes. Then they attach the external fixator to the Schanz pins. That K-wire is the game changer for joint protection.
It really sounds like it. You know, it makes you wonder, are there any downsides to putting that K-wire across the joint, even temporarily? Does it cause stiffness later?
That's a really important consideration.
Yeah.
And it's something surgeons weigh carefully. The idea is that by preventing the subluxation, which itself causes major stiffness and damage, the temporary immobilization by the K-wire is the lesser issue.
Okay.
Once the lengthening is done and the bone starts to consolidate, the K-wire is removed, usually around the same time as the fixator, allowing motion to be regained.
Yeah.
And in this case, they reported full functional recovery of the joint.
That's fantastic. So the temporary stabilization didn't lead to long-term problems.
It seems not in this specific case and with this technique. Careful placement and timely removal are key, of course.
Right. So surgery's done. The modified fixator and K-wire are in place. What was recovery like for this young woman?
Well, initially, she had to be completely non-weight-bearing. Strict instructions there to protect everything.
Makes sense.
And very regular, careful cleaning of the pin sites was essential to avoid those infections we talked about.
Diligence is key there.
Absolutely. Then, about 10 days after the surgery, once things settled down a bit, they started the distraction.
Slow stretching.
Yep, using a little dial on the fixator, 0.25 millimeters twice a day. So half a millimeter total per day.
Yeah.
Slow and steady.
And how long did that phase last?
They continued the distraction for 40 days,
Okay.
which successfully got them the 2 centimeters of lengthening they were aiming for on each foot.
And they monitored the bone growth with x-rays.
Yes, regularly, about every 10 days. The X-ray showed good callus formation. That's the new bone filling the gap.
A good sign.
A very good sign. And crucially, those X-rays also confirmed that the lileal arch, that metatarsal parabola, was restored. The alignment was back.
Excellent. So the structure was corrected.
Structurally, yes. The external fixator stayed on for 2 months in total, allowing that new bone to start hardening up. 2 months with the fixator, then it came off. Correct. Fixator and K-wire removed after 2 months. Then, after a bit more time for the bone to get stronger, what they call consolidation, she was allowed to start walking with full weight bearing around day 80.
Day 80, so a bit under 3 months post-op.
Roughly, yeah.
No.
And the results, the report calls them excellent.
What did excellent look like for her?
Restored alignment, anatomically. Full function back in those MTP joints, importantly, without any sign of that subluxation.
The modification worked.
It really seems it did. Complete resolution of the pain she'd had since childhood.
Yeah.
And no major complications, no deep infections, no issues with the pins or fixator breaking.
That's a fantastic outcome. Really life-changing for her, I imagine.
Absolutely. If we connect this to the bigger picture, these results really speak volumes about how effective this modified approach can be.
So stepping back, what are the main takeaways here? What does this case tell us about treating brachymetatarsia, and maybe about orthopedic surgery more broadly?
Well, first, it reinforces why distraction osteogenesis is often preferred for lengthening. That gradual stretch is just kinder to the surrounding tissues, nerves, blood vessels, compared to slapping in a big bone graft acutely.
Right, the biological approach.
Exactly. It avoids graft issues altogether. But second, and this is the core point, the modification was key. Adding that trans-articular K-wire stabilization directly addressed the Achilles heel of traditional distraction for this condition, the MTP joint subluxation.
Tackled the main complication.
Correctly. Prevented the subluxation, prevented the resulting stiffness. That's huge. Third, it really underscores how vital restoring that lileal arch is. It's not just cosmetic, it's fundamental to how the forefoot works.
Function follows form.
Precisely. And finally, the report suggests this modified technique is a safe, reproducible option, especially for younger patients who generally heal well and often have high expectations for both function and appearance.
It's a great example of that problem-solving mindset in surgery, isn't it? Identifying a problem with a standard technique and devising a targeted solution.
Absolutely. Constantly refining things to get better outcomes for patients. That's the goal.
So wrapping this up, the big takeaway seems to be that this specific modification, adding the K-wire stabilization during distraction osteogenesis, offers a much more stable process, minimizes those significant MTP joint complications, and leads to really excellent results for what can be a very challenging condition like bilateral brachymetatarsia.
Yeah, it's a powerful illustration of thoughtful surgical innovation.
A perfect example of what we try to do here on the Deep Dive, distill these complex reports into clear, actionable insights.
And maybe a final thought to leave listeners with. This case is a great reminder, isn't it? That even for conditions that aren't super common, pushing for innovation isn't just about fixing a physical abnormality. It's really about giving people back their function, their comfort, their confidence. It fundamentally improves quality of life. And it makes you think, where else in medicine could a similar kind of targeted, maybe seemingly small, modification to an existing method lead to significantly better results?
That's a great question. What other established procedures might have a hidden vulnerability that a clever tweak could solve? Something definitely worth pondering.
Indeed.
Well, thank you for joining us for this deep dive today. We hope you found it as fascinating as we did. Keep exploring, keep learning, and we'll catch you next time to unpack another set of sources.